Clostridium pallidum. And this is a spirochete bacteria, so they look like little corkscrews. Okay. And then with syphilis, this disease comes in stages. So it's usually primary, secondary, tertiary, and then you can also have neurosyphilis in there. Then it also goes into latent syphilis. Again, with this one, you can also have vertical transmission from the mother to the fetus, resulting in congenital syphilis. And then men who have sex with men account for the majority of new gonorrhea and primary and secondary syphilis. And in primary and secondary syphilis is where it's most contagious. It says here, women's rate of syphilis has increased more than 27% from 2014 to 2015. But women still account for less than 10% of all new primary and secondary syphilis infections. How's Oklahoma doing in syphilis? We're back to the same as we were with chlamydia. Or is it lighter?
Minnesota's doing pretty good.
Oh, it is lighter.
It's too cold up there for anything.
I know, all is great, but now look at Alaska.
We're the best in this one.
Alaska was really bad in which one?
Both of them.
Chlamydia. Chlamydia, that's right.
It was the worst thing.
I wonder if that matches sexual orientation patterns.
Lots of cases.
Because it's higher in
Like in California, yeah.
higher in MSM. I'm just curious.
Probably.
But Louisiana is the highest.
That's the only state that's worse than us in education.
Is Louisiana, that's right. So again, this is what it would look like under a microscope. And with these syphilis, these trichomona, or palladium, you can only look under dark field microscopy. You can't look under normal field. And again, it enters through breaking the skin, and again, any mucous membranes. And it's transferred through the placenta from mother to fetus as well. And you can have disseminated disease, which develops into neurosyphilis. So primary infection, you'll get, this is also always on boards or on a exam question, is with primary syphilis, you'll develop a chancre. So usually it's a painless ulcer on either the shaft of the penis or at the vagina. So painless, chancre. Always remember painless goes with chancre. And it's highly infectious. These can heal spontaneously in 3 to 6 weeks. You can have multiple lesions. But again, like I talked about, most contagious during the primary and secondary stages of syphilis. There's a chancre.
They look like they should hurt.
Right.
And you're like shocked, like, this doesn't hurt? And you're like, oh no, I've had another one before, it just went away, and you're like.
Then wait till I show you a chancroid. Then you'll know why those are painful. And that's a chancre on the tongue, the bottom picture.
Oh.
No, it's a tongue, sorry. Then there's secondary syphilis. So you get secondary lesions that occur several weeks after that primary chancre. And it can persist for weeks to months. And then mucocutaneous lesions are most common. So these, when I think of syphilis, I think of on the palms and the soles. But you get this rash, it could be papulosquamous. Then you can also develop lymphadenopathy. And then with secondary syphilis, they can also have condylomata lata. Condylomata lata. Again, you never order latte. Condylomata lata. And in secondary syphilis, their titers are going to be higher in this phase as well. that's condyloma lata. Yes. I don't remember if they are itchy. And that's nickel and dime lesions. It is. I don't remember them being itchy.
I don't either. I think it's, again, it looks like it should itch or something.
Especially the one that's the abdomen right there. And these are lesions on the palms and the soles of the feet. And then you have something called latent syphilis, kind of like, yes?
Can you go back a couple of slides to the secondary symptoms? What do you mean by this generalized boy?
Oh, this big body, generalized body. Oh, generalized boy, generalized all over your body. So you can have it on the trunk of your body, but a lot of times you'll see it on the palms and the soles. Sorry, you didn't even see that. And then latent syphilis, you can actually have the disease but not have any clinical symptoms. A lot of times the only way you can find that is by doing a serologic test, if you're tested positive for that. And there's early latent, so it's been less than a year duration, and late latent is greater than 1 year. And then neurosyphilis. So you can get neurosyphilis at any stage of the syphilis stages, and basically it's spread and causes neurologic symptoms. Did y'all talk about Hpv Strains? And so you can develop that. You can just get paralysis as well. And so tertiary or late syphilis, 30% of people progress to the tertiary stage between about 1 to 20 years. That's a big span. But usually this is rare because of testing. Usually people are tested early and then the use of antibiotics, and so they're treated. Yes?
What famous king of England had tertiary syphilis?
Oh, King George.
King George.
Because he had so many
Everything
wives.
is
Jeopardy someday.
Well, isn't he the one who had like a lot of wives?
Yes, many names.
And couldn't ever have like a boy.
No, he
Did he die of it? Huh? What? Okay, so with late or tertiary syphilis, you can develop gummatous lesions. You can also get issues with your heart, so you get cardiovascular syphilis. Gummatous lesions. Not horrible. Look at that person at the very bottom.
Are they alive?
I don't know. They kind of look mummified, don't they? That's tertiary syphilis. And then congenital syphilis, again spread from the mother to the baby. And with these you can have stillbirth, death of the baby early on at birth, and then disorders such as deafness, neurological impairments, and gum deformities. And again, transmission can occur at any stage of syphilis to the baby. Much higher, again, from primary and secondary because the titers are higher than those two stages as well. I can't remember if, are women automatically tested? I know they're tested for HIV, but I don't remember about syphilis.
Yes.
I can't
At
remember.
the initial visit,
Okay,
everyone. So we'll do that in prenatal lab.
okay, okay.
The blood supply is also tested for syphilis. Anybody?
Oh, really?
So all the blood is from OBI.
Oh, it's tested for syphilis before? So these are signs of latent, or found, you can find it at birth, or you can have delayed diagnoses. And these babies will have these signs. So under the palate, which I think on that first one it talks about, on the first slide. You can get these oral lesions up on the top of their mouth. It's kind of hard to see in that picture, but then they get these teeth, they're called Hutchinson's teeth, so they've got that little notched look on their incisors. And then you could also, so if you have a child that comes in and you see these signs, you might want to think about, this is like, I think, in the bottom picture, so that kid has actually a palate, there's a hole in his palate. And he was like 14, so he wasn't diagnosed with congenital syphilis until then.
What's in his nose? What's in his nose?
What's in his nose?
Is that a nose ring?
Yes.
Yeah.
And the kid?
Yeah.
Oh, I didn't even know, it's supposed to be from another country.
You gotta do it at the end.
Again, with all of these diseases, a good sexual history and physical exam that we do. Biopsy, you'll see the treponema pallidum, and then again, dark field microscopy. You can do serum testing. The qualitative is treponemal, and then non-treponemal is quantitative. I actually say quantitative and qualitative, but the ones that I'm most used to are the RPRs or Vdrls. And then to diagnose tertiary, you can do a lumbar puncture with Vdrl. That's one that you mainly would use for CSF testing. So RPR is a rapid plasma reagent. And this actually detects an antibody that's not actually for the T. pallidum, but it's a cardiolipin lecithin cholesterol antigen. So that's actually what it's testing for. So it's not sensitive, as equally sensitive to Vdrl. It's usually positive within 7 days of exposure, and then you can use this. It decreases as with time and with treatment. And then Vdrl, this one, like I said, usually is the standard for testing CSF. If you suspect someone with neurosyphilis, you would order Vdrl. 4 times a rise equals active infection, so if it doesn't decrease, they either have a new infection or there's treatment failure if you retest them. And then plus, if you test the Vdrl and you're suspecting neurosyphilis and it comes back negative, then they don't have neurosyphilis. It's that specific and sensitive to neurosyphilis. And then treponemal, which I've never done any of these. Did you ever use any of this? So this actually measures the antibody directed against T. pallidum antigens. But these are very specific, and so usually if you have a positive RPR or Vdrl, you could do one of these tests to confirm the diagnosis. Treatment. This is for primary, secondary, and early latent syphilis. Benzathine penicillin G. It's 2.4 million units IM times 1. And if they're penicillin allergic, those are the other 2 that you can do. And this is PO instead of IM. Latent and tertiary syphilis, benzathine penicillin G. So there's a common theme, right? Benzathine. What do you think treatment of neurosyphilis? It's aqueous crystalline penicillin. So if you have penicillin as a choice on your exam, choose penicillin. And I don't remember, was this ever a board question? Do you remember Jarek's Herxheimer reaction? So it's actually not a reaction to penicillin, but it's a reaction to those being treated for syphilis, which I thought was kind of interesting. So how is it not a reaction to penicillin? But I thought I remember that being a test question at one point, whether it could have been in school or if it was on a board question.
I must have missed it.
That's just a reaction you can get from taking treatment for syphilis. Yes.
Can you give congenital little babies penicillin, or is it contraindicated that young?
For babies, I can't remember the dosing. Can you give penicillin? I thought you could to
I
babies.
think so. They gave it to me when I was in labor and he got it.
I'm pretty sure you can. I know that my daughter got gentamicin when she was a baby, and I remember it being side effective ototoxic, and I had to get her urine tested 1 year later, and she was a newborn with the gentamicin, so I'm assuming they could give her penicillin, give me penicillin. Lumps and bumps. These are the really cool pictures. So chancroid, genital herpes, and gliomas. The chancroid. So this is a bacteria that's usually only transmitted through sexual contact. Incubation time, 1 to 2 days after intercourse. You can have a small bump that turns into an ulcer that same day. It's not common in the US, but usually it's in developing countries, low socioeconomic areas, and commercial sex workers. So don't go to Thailand. And the bacteria, or the bug, whatever you want to call it, is Haemophilus ducreyi is what causes it. It is a gram-negative streptobacillus. And what was the one that does, which bacteria is it that you test with acid fast staining? Who said that?
Tuberculosis?
Good job. So chancroid is painful. What's not painful? Chancre. So these can be bigger. The chancroids are bigger, usually again on the shaft of the penis or the labia of women. Men typically only have one ulcer. Women can have multiple of them. Again, it's tender, and they can have suppurative lymphadenopathy. These are usually soft edges, and they'll have like a yellow base to it, kind of like what a herpes lesion might look like. Now, tell me if that doesn't look painful. Yeah, you can see, look at that suppurative lymph node, that lymphadenopathy.
Are they disfigured after that?
Huh?
Are they disfigured?
No, I don't know.
I can't go back forward.
Oh, this is even worse. So this is a female with chancroid. So again, females usually have multiple of them. So do you see that yellowish base to them? They kind of have a more softer edge to them. They look like herpes, right? So that's one of your differentials if you saw a female that came in with multiple lesions like that. But the herpes ones look a little bit different. How do you diagnose it? You do a culture. But you can also assume someone has a combination of painful genital ulcers and then the suppurative inguinal lymphadenopathy. You would suspect a chancroid. And then how you rule it out is you would do, you could do, if you had a microscope, you could do on dark microscopy, roll out the T. pallidum, and then serologic testing for syphilis, and then herpes simplex, which is a Hsv. You do the PCR testing, as well as culturing an ulcer. You can actually take a scraping from and culture it that way, and set those off. Treatment, these are 4 different options. Azithromycin, 1 gram in a single dose. What other STD can you treat that way? And then ceftriaxone and azithromycin is. So you want to see them pretty quickly after you've treated them, because they should improve once you put them on the antibiotic. Treat all partners. Treat all partners and their partners.
You could have other partners.
We're talking trees here. Yeah, yes.
You guys don't think about that, but it's true.
So you want to treat them because they may be asymptomatic until the lesion appears. It may appear 7 to 10 days later. Obviously, so remember I talked about it can cause scarring, so I'm assuming that guy, it may not have grown back, he may have been scarred for life. So no documented adverse reactions while pregnant. Again, common in HIV patients. Why are all these diseases common in HIVs? And,
Because they are women that have syphilis.
right, and they're usually sexually promiscuous. So this is just a little thing you guys can read later, kind of helps you differentiate between a chancre and a chancroid. Gift that keeps on giving. Sad but true. Or one of my poor girlfriends unfortunately got this from one of her ex-boyfriends. And so she had to deal with that the whole time, like when she was pregnant with her child, about delivering him vaginally, and then she still now is having issues with it because now she keeps getting all these weird abnormal paps, you know, and so it's horrible. So genital herpes is a leading cause of genital ulcer diseases worldwide. So there's HSV1 and HSV2. So HSV1, you all remember, is usually mouth ulcers, mouth sores. Then HSV2 is usually genital. And there, at one time, there was a cross, so sometimes you could check and there's like HSV1/HSV2. I don't know if they still delineate those or as one whole different one. But the majority of ones that cause genital ulcers are HSV2. Again, like I said, it's chronic, lifelong, and this too, they can be transmitted even if you don't have symptoms. So that's what she worried about when she got married to her new husband, is when she transferred it to him because she was never symptomatic. So genital HSV2 infection is more common in women than in men. African American, usually older ages, and those with increasing numbers of sexual partners. And then genital HSV1 infection is usually young women, college students, and men who have sex with men. I will say this last year was the first time I actually saw a primary HSV infection. So if you have a young person walks in your office who looks like she's been riding a horse for about 2 days, it is herpes unless proven otherwise. Because when I saw her, she had no lesions, but it was just so painful. You know, she had diffuse cervicitis, but you were looking at it, it looked like it could be BV. It was thin, you know, but it was a lot of it. It was a lot of it. She was real swollen, real tender, so even doing a pelvic exam on her, I thought she was going to jump off the table. So if you see that person walking in like this, and it's a female, she has HSV until proven otherwise. Again, transmitted through mucosal linings during sexual intercourse. Now you can, you know, remember it used to be HSV1 was the kissing. You can transfer it that way to your partner. So if you can transfer it lip to lip, you can also transfer it during oral sex as well. And then transmission of HSV2 often involves asymptomatic shedding. So most of the people who transmit HSV2, they are not having any symptoms when they do. And transmission is greater from men to women than women to men. So her risk of, like my friend, her risk of transfer to her husband was less likely. It'd be higher if he had it and transferred it to her. Again, you can also give it to the baby, so she worried about that, and she delivered her son fine, didn't have any problems. And you can have fomite transmission. It's unlikely, but you can also get particles, and you can actually inoculate your fingers, your eyes, same things. And so here in a minute we'll talk about, I'll show you a picture of herpetic whitlow. There it is. So sometimes if you have an ulcer in your mouth and it's a kid, probably this looks like a kid, a thumb sucker, they can give themselves herpetic whitlows. So signs and symptoms, like again, most of these people don't have any symptoms. But now, like I said, you can have a primary infection. So primary infections is usually their first infection. They've never had either HSV1 or HSV2. It's going to be the most painful. Subsequent reactions or outbreaks generally aren't as severe as the very first one. Primary infection, like I said, is someone who has never had either HSV1 or HSV2. Or the antibody, I'm sorry. So they have either HSV1 or HSV2 without having an antibody to HSV, or to either type of HSV. And then you could, like if you suspected they had it, treated them, you can check a antibody, IgM, about 12 weeks later, and those should become positive. These are general symptoms they may have: fever, malaise, muscle aches, swollen tender lymph nodes. And again, this is the primary infection, so they'll have small, painful vesicles. They kind of look like, anybody who's had herpes on their face, so they kind of look like that. They're usually fluid-filled vesicles. With herpes, they're usually, they again have like a yellow base, and I think with these they actually have like more of a redness around the outside border of the vesicles. So with these, you get the prodrome of the burning and itching pain before the ulcers actually appear. Does anybody have cold sores or get them? So you know that tingling sensation you get around before the little blisters show up? You don't ever get that?
Yeah,
Oh,
that's what I
that's right. My husband usually knows when he gets it, he'll get a tingling, and then he'll have some acyclovir that he'll take to help prevent them from actually cropping up. Or if he does get a flare-up, it won't be quite as bad. When the blisters break, they leave straddle ulcers. They're very painful. They eventually crust over, slow, and heal. It's kind of like chicken pox. So these people can also complain of dysuria, vaginal or urethral discharge if they have the cervicitis, and then tender inguinal adenopathy. In women, HSV shedding from the cervix occurs in 80 to 90% of primary HSV1 and HSV2 infections. So this girl, when you looked and did her pelvic, she had a lot of drainage coming out of her actual cervix. So she had cervicitis rather than the urethritis. And hers, it also looked friable. So friable means the tissue around it just looks like it could just fall off. It looks red and inflamed. And when you see friable, you'll kind of know, you'll know what I'm talking about when you actually see it. Like anytime you take one of the little scraper things, you scrape it, it's like almost like the skin and tissue will just fall right off of it. Infection, again, with the urethritis or meatus may cause a clear mucoid discharge. So I don't know if you can see that. You see the small little ulcers all around there? Doesn't that look painful? And see at the very bottom, if you can see that, you see that white discharge, that's probably more likely the discharge from the cervix. But you can tell her labia minora is really swollen and irritated. Another picture, so on the head of the penis, and then closer up of the vaginal herpes. That was painful. And this is over the rectum. Thing. That's horrible. So then you have non-primary HSV infection. So that's somebody who has had, maybe they had HSV1 as a child, then they end up having so they already have antibodies to it, then they develop HSV2. So it's a non-primary HSV infection. So in these people, they already have antibodies. So when they get infected, let's say with HSV2, their disease will be more mild. Their outbreak won't be as diffuse and won't be as bad as the primary outbreak, because they have what's called a cross-immunity protection from prior HSV infection. Secondary outbreaks can occur weeks to months later, and it's, like I said, it's less severe, and if a patient has more than 3 outbreaks, so you'll find that you'll have patients come in that keep getting either mouth ulcers, or they have recurrent genital herpes outbreaks, so you can give them suppression as well. lays dormant until reactivation. So yes, so these people a lot of times are asymptomatic, they don't even know they have it, they're shedding, they're passing it on to someone else unknowingly. So see, this is recurrent, so see how much, there's only a few lesions on this one compared to that first primary. And there's a couple of lesions on the other side of this. Yes. And how do you diagnose this? You culture it. So you can unhoof one of the vesicles and test that. You could do a PCR for Hsv DNA. Again, you could do tests for antibodies, but like I said, it won't become positive for 12 weeks, so there's no point of testing for antibodies right off the bat, unless it's a recurrent, or a second episode. You might want to check it to make sure that they've had prior antibodies. And that's just how to know good and bad, which is more an acute versus an old infection. You can do, like I said, scraping, and you're looking for zinc cells or a zinc smear on the slide. And you stain it with what's called white stain. And you're looking for these giant cells, and they have multiple nuclei. So see that one cell, there's like 3 or 4 of them in that one. You're looking for giant cells, and that's a zinc cell. And these are the treatments that you can do for primary outbreaks. You can give acyclovir, 400 TID, 7 to 10 times a day. You could do 200 milligrams 5 times a day for 7 to 10 days, which I don't know why someone will do 5 times a day. Famciclovir, valacyclovir, it's less dosing, it's 1 gram twice a day. So a lot of times I would want to write patients for valacyclovir, but their insurance won't pay for it, and it's usually pretty expensive, so then you have to go back to acyclovir. And you can extend the treatment if they don't improve after 10 days. Again, this is secondary outbreak, same drugs. But usually, it's at 5 days, but again, I always treat, when I see some things like 10 to 14 days, I'll usually treat 14. 7 to 10 days, I usually always treat 10. And then this is suppression. So this is something, if someone has more than 3 outbreaks in a year, then you could give them suppressive treatment. They'll take a pill daily. And then those who get HSV1 outbreaks, you can also take something called lysine. Take that once a day. It's just a over-the-counter supplement that you can take as well. And so sometimes you get severe disease, and then they'll have to be hospitalized and given IV acyclovir. Because these people, you can get dissemination and get meningitis symptoms into this meningeal complications. So this one is acyclovir, but it's IV for 2 to 7 days. And then you also, once you discharge them, you put them on oral antiviral for another 10 days. So same counseling as any other STDs. Have the partners checked, treat them. So main barrier treatment is latex condoms. Like I said, but most people, especially younger people, don't know that birth control doesn't treat and cover for STDs. You'd be amazed how many don't believe that. Transmission during pregnancy, you guys can kind of read through that. Again, treating with acyclovir. And then HPV condyloma, what side am I on?
117.
Yes. See, I'll be done by 3. So HPV. If we were to test all of us in this room at one time or another, we would probably have had HPV. The guidelines have changed. Back in the days when I was in college, I remember girls would have to go get colposcopies and freeze their cervix and all this kind of stuff. Nowadays, they say HPV is self-limiting. Most younger girls will, get rid of it on their own. Their body will overtake the disease, is what they say. So nowadays, most people, if they get HPV positive, they won't do anything for young girls. They'll just let it kind of go, which kind of scary to me. So the types of HPV that cause genital warts are non-oncogenic, and then there's the types that cause cervical cancer, and those are oncogenic. So we'll kind of talk about those today. Genital warts, you'll see this a lot. You'll have people come in and say, oh, I've had this skin tag on the base of my penis forever. Well, it's not just a skin tag. You shouldn't have a skin tag there unless you're zipping up by accident. But the types that cause genital warts are condyloma acuminata. What's the type that's associated with syphilis? Lot. Right. So condyloma acuminata is with HPV. Condyloma lata is with syphilis. Okay. So HPV types 6 and 11 are responsible for 9% of genital warts. It's, again, highly contagious, spreads skin to skin, oral, genital, or anal sex. 27, which is, I thought was kind of high, 27% of all sexually active people have genital warts. 45% between the ages of 14 and 19. Again, I think it's because of education. You know, no one wants to talk about that anymore. And unprotected sex with an infected partner results in 70% chance that you will become infected. That's pretty contagious. Onset is usually 3 months after contact. And then the high-risk HPV strains are 16 and 18. Those are the ones that usually cause cervical cancer. Now there's a whole ton of other ones, so there's other high-risk HPV viruses. And so usually when you're getting your pap smear, they'll usually test for the high strains. So every year, over 27,000 women and men are affected by a cancer caused by HPV. That's a new case every 20 minutes. That's a lot. So HPV can cause cervical, vaginal, or vulvar cancer in women, and penile cancer in men. And it can also cause anal cancer, throat cancer, and genital warts in both men and women. So when I worked in head and neck, we used to have a lot of people, we would test, if they had tonsillar cancer, we would test for HPV. And actually, if you were HPV positive for a tonsillar cancer, you actually had a better outcome because there's treatment, better treatment options for HPV cases. So we used to see a lot of that. Cervical cancer is the most common HPV cancer. Almost all cervical cancer is caused by HPV. So, and I think Ken Brooks, he's a PA, he'll come and speak with you guys next week about cervical cancer. No relation. I don't think Ken will tell you, but how I met Ken was when I was a PA student, I was on my cardiology rotation, and I was rounding with my attending, and he was in there. And I was like, what? Oh, maybe I shouldn't tell you. Maybe it's a HIPAA. He's not my patient, is it? Huh? Shouldn't say it? Okay, never mind. Signs and symptoms of condyloma usually occurs in clusters. They range from very tiny, they're usually flesh-colored, again, around the genitalia or the penis, and sometimes they can have little stalks on them. So that's why some people can confuse them for skin tags. Skin tags have little stalks on them. Usually on the outside or the inside, but majority of them you'll see on the outside walls. Genital warts can also develop in the mouth and throat, that's what we kind of talked about. So cervical lesions are found in more than 1/2 of females with external lesions. If you see anybody with an external genital wart, you should do a pap smear on them. Not a pap smear, but a pelvic exam on them to look at their cervix. And you guys saw those little cervix mannequins yesterday, how it all looked different on the top. So you need to really look for, when you're looking at the cervix, you're looking for white, things that doesn't look right. A little bit of red around the outside is fine. A lot of red is bad. White is usually bad around the cervix. condyloma, nada. And there was one lady, I had a patient that I think I could have sworn I thought she had like a big, bad case of condyloma. Turned out she actually had really bad external hemorrhoids. They made it look bad. And I was like, oh my God. And she was so nervous she didn't want my attending to see, so I was the only one. I sent her to see a colorectal surgeon to look. And it turned out it was just a bad case of hemorrhoids. And when it was out like that, I mean, it was really bad. It covered her whole rectum. More condylomos. So, how do you diagnose it? Physical exam. So you take a look, and usually, like I said, you'll see clusters of them in the vaginal rectum or around the penis. And you can actually apply acetic acid, so it'll turn white, and it'll give you a positive finding of condyloma. And you can also take a biopsy of it as well, if you're unsure. So how to treat it? You can give them a cream, Vdrl. You could also do liquid nitrogen. And actually, we had this a case in the clinic not too long ago. No, that was molluscum. I'm sorry. We used a straight edge blade to scrape off the molluscum. Tell me that didn't hurt. And then you can also refer them to dermatology because it may take it'll take a long time and part of recurrent treatments to get rid of it. Special points are vaccines. So the vaccines are recommended for preteen boys and girls. You know, it used to be just for girls. Now they're recommended for boys and girls ages 11 and 12. And these are the different types: Gardasil, Gardasil 9, and there was a new one that was called Ceravax. But these don't cover, that last one doesn't cover the strains of genital warts. It's mainly for the oncogenic ones. But you know, there was always a debate whether or not you want to vaccinate your child for HPV. I'm one of the ones that are pro-vaccinations, and you know, it's just like chickenpox. If you can avoid it, why wouldn't you? You know, if it decreases your child's risk of getting a bad cervical cancer or vulvar or penile cancer, I'll do it. And then vaginitis. So vaginitis is a big broad term that basically is inflammation of the vagina, and usually caused by some type of infection. The most common causes are the ones we've already talked today, the STDs. But then you can also have candidiasis or bacterial vaginosis, or in some women you have atrophic vaginitis, where the walls of the vagina get really thin and dry, and it gets really itchy, and you get hypopigmentation from the itching, but that's atrophic vaginitis. So in the older women, that's why you would give them estrogen cream and things like that. And then you can have, like I said earlier, you have normal vaginal flora, and that's lactobacilli, corynebacteria, and yeast. So we all normally have yeast in our bodies, but when you get a candida infection, it's usually from overgrowth of that yeast. Normal postmenstrual and premenopausal vaginal pH is usually between 3.8 and 4.2. So usually when your vaginal pH gets off, that's when you can develop some of these diseases. And some other reasons, you know, feminine hygiene products. So you know, if you douche, that can cause an overgrowth. Vaginal medications, contraception. So sometimes people can have reactions to the spermicides on condoms, things like that. And a lot of times, a lot of them maybe if you don't urinate right after having intercourse, those kinds of things, you build up all that bacteria in there. So recurrent vaginal infection, so a lot of these things can itch, so you get excoriation, you can get hypopigmentation, scarring, and then psychosocial and emotional stresses are not uncommon. So if you get, you know, recurrent BV, that you have this recurrent discharge, recurrent itching, or anything like that, it's very stressful to women. You know, a lot of times when you're looking for someone who has recurrent candidiasis, what should you suspect? Diabetes. Okay. So in addition, chronic vaginal infections can lead to transmission of STDs because you have that chronic inflammation, open skin, and leads to high risk of getting some type of STD. Again, usually incidence highest among young, sexually active young women. Just signs and symptoms, same thing. Irritation, most women will come in saying, I have this discharge. Again, you're gonna have to ask them about the discharge. Are they having any itching? Are they having any burning with it? Burning when they urinate? Is there any odor? Does it smell funky? So as with BV, you'll have a fishy vaginal odor with it. Yeah, bacterial vaginosis. So what causes it is Gardnerella vaginosis. And, you know, the debate was whether or not this was an actual STD. And, you know, I talked to my gynecologist about it. She said it's actually just an overgrowth. It's not really an actually STD. It used to be thought of as an STD. Female partners of women with BV have an 80% chance of getting it. So these are different risk factors. Read through those. So symptoms of BV. So they'll have a thin, white, or gray discharge. And again, like I said, it's usually foul smelling. So fishy odor equals BV. And then when you put it on a slide and you look at it under a microscope, you're looking for clue cells. And then when you do a wet prep, you can prep it with KOH and you do what's called a whiff test. I've never personally ever done a whiff test. But usually when you're down there getting a sample, you can kind of take a whiff, but it's not the same because you don't have any KOH down there. But a positive whiff test usually is indicative of BV. And nowadays, if you actually get a swab of it and you send it off for culture for BV, they'll say whether it's a positive or a negative whiff test. And it gives you this rating scale on, I think it's like 4 and above is a high risk of its BV, 4 below. Because a lot of times it can look just like it, you know, and you think it is, and turns out it's not. It's just normal vaginal discharge. With BV, the treatment is metronidazole. You can do also Metrogel. It's a suppository that they put in every night for I think 5 days maybe, intravaginally. And then you can have recurrent BV. And you can give them Flagyl for a long time. I don't know the tea tree oil. So, but mainly it's metronidazole. And it's just talking about clue cells. And that's the whiff test for bacterial vaginosis. So see, that's more of a thin, milky looking discharge. So sometimes it's hard to tell between that and chlamydia, you know. So that's why you culture it and send it off. But usually when you do a pelvic exam on someone with BV, when you put the speculum in, it will usually just float at the bottom of the speculum. You'll see quite a bit of discharge for BV. That kind of almost looks frothy too. Vaginal candidiasis. So the causative agent there is Candida C albicans is the most common. It's not an STD, but you can get it from a male. These are the risk factors in here. A lot of times people will say, oh, if you're going to give me a prescription for amoxicillin, I need a prescription for diflucan as well. So you'll hear that a lot out in practice. A lot of people, when they take antibiotics, they usually get a yeast infection after that. Signs and symptoms. So with a yeast infection, most of the people will have burning and itching. And then they can get discharge that's usually clumpy. They call it cottage cheese-like is what they call it. It's curd-like vaginal discharge. And usually they'll have vulvar dysuria, so from all the itching and all the scratching when they pee, and that pee just burns around the vulvar area. candidiasis, and that's budding in hyphae under a microscope. There's taking what it looks like too, I'm not even lying. So on a quick prep, you're looking for hyphae and budding yeast. You can do a KOH prep, because that way it kills most of the bacteria. You can really see the hyphae under a microscope. And their treatment is diflucan, usually 150 milligrams 1 PO times 1. Usually when I would write it, I would give them 150 PO times 1, comma, repeat dose in 2 days. So I usually give them a second dose. Don't have to, but I generally do. Because, or you can give them diflucan, 100 milligrams 1 PO times 3 days. And PID, I've kind of gone through that ad nauseum, so this is just a little bit. So PID, kind of we talked about, is usually from untreated STDs, right? Usually from which two? Gonorrhea and chlamydia.
Are you gonna tell them what I call it?
Oh, she calls it pus and there. And there. PID, pus and there. So most commonly associated with chlamydia and gonorrhea. So again, you get the abdominal pain, vaginal discharge, you can have intermittent or intermenstrual bleeding. So with PID, which I mentioned earlier, is on physical exam, you'll have cervical motion tenderness. So when you're doing their biannual exam, they'll want to jump off the floor, or off the table.
I don't remember what that sign is.
Chandelier sign. So they'll have anaxial tenderness.
Predated Sia's sign. So the chandelier sign
Right.
predates Sia's recent sign.
Right, that's right, before.
Yeah.
So diagnosis, you would do a UA, excludes cystitis and pyelonephritis. You'll want to do, you could do a urine PCR for GC and chlamydia. So you also want to do a pregnancy test. So every sexually active female is pregnant until you prove otherwise. Before you put them on any antibiotics, check a pregnancy test. Because what happens if you give them Bactrim in the first trimester, you know, you're going to get fault. You kill that baby. PID is the most common incorrect diagnosis in missed ectopic pregnancies. While it's rare to have PID in pregnancy, you can have it usually in the first 12 weeks of gestation. So wet prep, so you look for numerous WBCs. Treatment, doxycycline or azithromycin. And so if you have more intra-abdominal abscessing or you want to give them something that would be more wide range covering, so you give them clindamycin or metronidazole. And then if they have an IUD, you must remove it. I did that when I was a student too, was remove an IUD. Complications, you can develop sepsis, ectopic pregnancies, like we said earlier, can cause infertility. And again, there's that Fitzhugh-Curtis syndrome. So prevention. So it's your job as future providers to educate your patients. Tell them safe sex practices. I always write it on my discharge summary over at the clinic. I tell them, you know, especially if you're going to give a patient who is on, if you're going to give them an antibiotic and they're taking birth control, I always make sure to tell my patients that you have to use some other alternative method of protection while you're taking these antibiotics. And I always tell them use protection, because that birth control will only prevent you from being pregnant, but not all the times. So you have to use other forms of protection. And it is really amazing to me how many women, young women and men say, oh, I use protection sometimes. It only takes one time to get pregnant or get an STD. Sharing is good. So I have to tell my kids.
STDs are just adult versions of cooties.
That's right, yes.
How is, for yeast infections, how is diflucan different from, like on the drugstore? They always show on the commercials, they're like.
The monostat,
How's it different?
I don't know what the actual brand name of monostat is, do you know? It's something, is it an azole? I don't think it's an azole though.
Yeah, that's just, I mean, what, you know, Diclofen's oral, you take it oral.
Mm-hmm. Monocyphilus suppository.
You do topical stuff, you have to do it longer.
Okay.
And I know
Not
people,
much longer.
some women who do get yeast infections use that over-the-counter monostat, and they find that it works, but a lot of women will say, it doesn't work, I need oral medication.
I didn't know if that was just their marketing of like, I got the prescription and it didn't work, if monostat actually works better.
It is an azole.
It is an azole. So probably just a topical versus an oral
Okay.
medication, but most women don't, they.
That's good marketing.
I wondered if that was the case.
Questions? So remember, learn the disease with discharge, go forward, how do you diagnose it, and then go backwards. If I gave you a scenario where they have on a wet prep, you see clue cells, what do you think it is?